We're going to talk today about the role of dynamic CT and MR and fusion of these concepts to help us understand the problem of false lumen intervention. Let's start off with what are the considerations in treating patients who have complex type B dissections. By and large, we place stent grafts, and by and large, the role of a stent graft is to induce false lumen thrombosis during both primary and indeed in secondary interventions. The idea is we open up the true lumen, we potentially reoppose the septum, and or we induce thrombosis at the same time. We know that the longer the coverage, then the more efficacious the intervention, but this is associated with a higher paraplegia rate. So clearly there's a trade-off, and we'd like to minimize the amount of coverage to achieve these reperfusion and thrombosis goals. What controls the thrombosis of a false lumen? Well, we think of it as vessel compliance, or more accurately, septal compliance. Can we push that septum up against the outer wall and get healing? We have to reduce the flow below a certain threshold in which thrombosis occurs. What are those factors? And there's probably also a thrombogenic factor that we really don't begin to understand. However, we think that understanding these false lumen patterns, the compliance of the septum, are going to be important in trying to make these objective decisions. The false lumen is a very complex environment. It doesn't just have an entry point. If you look at these two specimens, the same patient, on the right side, you can see the origin of the right renal has been completely evulsed. It's still flowing. And on the left side, there's a bridging tube of intima media, which has not quite evulsed at that point in time. But in addition to this, there's multiple holes in the intercostals, as well as often major and minor entry and re-entry points. The CAT scan is unparalleled in terms of its spatial resolution. It can let us see these little holes. Challenges are that their holes are moving, and so EKG gating may be important for us. MR, on the other hand, has less spatial resolution, but is much more highly quantifiable in terms of the flow, which we think is going to be important, and we'll examine this in a little bit more detail. Here you can see an example of a dynamic CT scan, and so again we're starting to use this fairly liberally in our center, and it allows us to see how the celiac, the SMA are perfusing, and or the renals are perfusing, and it lets us see how flow patterns are occurring, for example, in the false lumen. In this case, we can see distal to proximal flow occurring in the false lumen. Understanding that is fundamental to making logical decisions about stent graft coverage. MR is very powerful, but much more dependent upon the local expertise. The 2D cine MRI can be used for assessment of the septal motion, i.e. compliance. 2D phase contrast MRI can be used for flow assessment. Time resolved or twistless to see what these flow patterns are, as I showed you, flowing from distal to proximal. T1 Vibe can give high resolution imaging to look basically at septal maturation. 4D flow MRI, which of course is the real area of interest at the moment, allows us to real-time measure these flow patterns. And there's a number of different second-party companies that are creating the software to allow that analysis. And here's an example of the power basically of cine time resolved MRI. You can see a dissection in the top four planes extending, in this case, into renal artery or into supramesenteric artery. We can see how the septum whips backwards and forwards because it changes through one cardiac cycle. We'll show this in a little bit more detail as we go on through this. The twist allows us to show these patterns. And again, you can see the false lumen, again, filling from distal to proximal, same patient as we saw on the CT scan. So again, here, the majority of this is perfusion through a distal re-entry point. Obviously important to know. Now, a lot of the validation of things we're talking about have been done ex vivo. Now, this is a report basically from our group using a very unique pulsatile flow system created for us from ExxonMobil through what we call our pumps and pipes collaboration, in which we can control the pressure volume loops. The model of a dissection from an explanted pig aorta was used to create entry points. And this was then mounted and put back in the MR, and allows us to actually measure flow at the various different points in determine whether there's forward, reverse flow, and control the magnitude of the fenestrations. And of course, obviously, the whole point of this is now to actually get into human observations. MR, of course, is widely used In the cardiac world, it's used for looking at valve function, wall motion function. You can see the flow in the descending thoracic aorta. And on the right, you can see in this same patient in these 4-chamber views, they've also got dissection. And you can see how this is one cardiac cycle that's repeating. You can see almost a spiral flow pattern in the false lumen. And you can see the septal motion. And we believe that septum, as the septum matures, that motion decreases. And there are logarithms which allow us to actually measure that. We think it's important. It shows you the power of dynamic obstruction. You can see the pinchcock effect of the false lumen wrapped around that bridging tube that's still attaching the true lumen to the left kidney, and it gets pinched during each of the cardiac cycles. Ultimately, what we really want to be able to do is measure volume flow in that kidney, allow us to make objective decisions about the need for intervention for dynamic obstruction. Very powerful. Now, if you look, here's another example of how you can really see this remarkable septal motion. I'm going to go back and play that one more time. Remarkable septal motion. Go from almost complete obstruction to being wide open. And in this candy cane view, what you can see is the repeated motion that occurs in the septum, but these black and white lines, which you can actually see here, and we're pointing out here, represent to and fro motion through multiple avulsed intercostal vessels. And so, again, it's not just the magnitude of or the size of the entry point, is the composition of all of these components, which are going to be important in determining the interventions, how effective they're going to be, and whether or not you get false lumen thrombosis actually occurring. Now, in the past, after all this data was acquired, you used to have to wait, almost overnight, because the computational fluid dynamics would actually derive and impute a lot of these flow patterns. But what has really changed about this is that this can now really be done at the same time as the MR is being acquired. It certainly prolongs the acquisition sequence, but it allows you to measure real 4D flow. It's not derived, it's not computed, it's actually measured. And this, we think, is what's really going to help us. So here's an example of a patient with a chronic type B dissection. And here what you see is what these flow patterns look like. This is one cardiac cycle repeating. You can see obviously a huge amount of data. We can actually break this down. We can magnify it. We can analyze it. And now you can see the jet basically for the entry point, high velocity jet, and you can see the spiral flow pattern. And what we really want to be able to do is try and ask the questions: if I covered X square centimeters of entry and re-entry points, what will that actually do to thrombosis basically in the false lumen? And so the advantage is that we can break this down basically into this mesh, which represents the aorta. Each one of these little areas can be solved in terms basically of the volume flow. We can measure shear rate, we can measure compliance. And so I think you're going to start to get tools which allow you to analyze these flow patterns and perhaps allow us to predict that pre and post TVAR effect of lack of flow in the false lumen. It's where we're obviously going to go with this. And, it's this combination of the information of CT. Obviously, we can't acquire these things at the same time, but what we can do is acquire them in roughly the same hemodynamic setup and relative temporal proximity to one another to try and model this in 3 dimensions and understand it. You can bring these two together basically with fusion, and it allows us to ask specific questions of these very specific regions. And hopefully it's this understanding the geometry and the hemodynamics will let us make more rational stent grafting decisions going forward. So in summary, CTA has much better spatial resolution and enables better imaging of septal fenestrations and aortic dissections. Cine and time-resolved MRI sequences enable temporal imaging of blood flow patterns and true and false lumen. Combining these data sets will provide us with comprehensive imaging and understanding or assessment of aortic dissection. And we really believe these novel imaging techniques with dynamic CT, 4D flow MRI will further help our understanding of not just dissections but multiple aortic pathologies. Thank you.